welcome to this episode of OncLive Breast Cancer Talk, a review of data from the ASCO 2020 virtual meeting. I'm your host, Dr. Sarah Hurvitz from the David Geffen School of Medicine at UCLA. Joining me today in this discussion are my colleagues, all experts in the field of breast cancer. Dr. Aditya Bardia from Mass General Hospital Cancer Center, Dr. Claudine Isaacs from Georgetown Lombardi Comprehensive Cancer Center, and Dr. Sarah Tolaney, also from the Dana-Farber Harvard Cancer Center. Today we're going to talk about key data sets presented at the ASCO 2020 virtual meeting. We'll talk about the impact on clinical decision-making and treatment selection for your patients. Let's get started on our first topic. So let's first talk about the Parsifal study. In this study, patients with hormone receptor positive metastatic breast cancer that was previously untreated in the advanced setting were randomized to receive fulvestrant or letrozole. All patients received palbociclib. Patients had to have endocrine sensitive disease, defined as either fully naive to prior endocrine therapy or relapse more than 12 months from adjuvant endocrine therapy. Aditya, can you briefly talk about the rationale for evaluating AI versus SERD in combination with the CDK4/6 inhibitor in this setting, and why is it relevant to our everyday practice? Maybe go over some of the results with us, which were a bit surprising, I think.
I agree. We were a bit surprised with the results. So the rationale for the study was, we know that endocrine therapy plus a CDK4/6 inhibitor is associated with better outcomes than endocrine therapy alone. And in terms of endocrine therapy, essentially there are two options. One is to use an aromatase inhibitor, which lowers estrogen. The other is to block ER directly with an ER degrader like fulvestrant. The question was, if you use different endocrine therapy backbones, AI versus fulvestrant, but keep the CDK4/6 the same, would that be associated with better outcome, just suggesting that one endocrine therapy might be better than other. And in part, it was suspected that fulvestrant plus palbociclib would be better than AI plus palbociclib because of the data from a number of randomized trials. If you look at randomized trials that have compared AI with fulvestrant, the studies have shown, like Falcon, have shown that fulvestrant is better than AI in terms of improving median progression-free survival. And we also have provocative data from Mona Lisa 3, which looked at fulvestrant plus ribociclib and demonstrated a median progression-free survival that was more than 30 months, much higher than what was seen with AI plus CDK4/6 inhibitor, be it Mona Lisa 2 or Paloma 2 or Monarch 3. So it was suspected that fulvestrant plus a CDK4/6 inhibitor would be associated with better outcomes as compared to AI plus a CDK4/6 inhibitor. And that is exactly what Parsifal was designed to do, was to compare these two arms. Surprisingly, the study showed that there was no difference in median progression-free survival between the two arms. Patients randomized to AI plus palbociclib did as well as compared to those with fulvestrant plus palbociclib. The team also looked at subsets, patients with visceral mets versus not, and there was no difference, suggesting that at least in the first-line setting, AI plus palbociclib or fulvestrant plus palbociclib, both are reasonable options to consider for a patient with metastatic disease.
So Claudine, what's your takeaway here? How are you choosing between aromatase inhibitor and fulvestrant in combination with the CDK4/6 inhibitor?
So I think for patients who have relapsed more than 12 months after completing their AI, I have to say I was thinking of our patients, I was sort of happy with these results. I think it frees our patients. It's nice it was surprising because I think we all thought that fulvestrant might be a better partner based on some of the data that compared directly AIs to fulvestrant. But I think from a quality of life perspective, it's much nicer to let our patients not have to come back to the infusion unit every month to get a fulvestrant injection. So giving them oral medication and telling them that it's equivalent, I think was a positive finding for our patients. For our patients, though, who relapsed within less than 12 months, who relapsed on an AI, then I think obviously what we would be doing would be using fulvestrant as a partner.
Yeah, I agree completely. And I too am very interested in having that ability to select. Some patients have a lot of toxicity from AIs with the joint complaints, so the ability to choose to switch over if that were to occur is nice. I think it is going to make the field of oral SERD development quite interesting now. How are they going to show, do they need to show superiority? Is non-inferiority going to be adequate in that setting? Sarah, let's move on a little bit to the BELIEVE study. Results from cohort A of the phase 2 BELIEVE trial was presented by Hope Rugo. This is evaluating alpelisib in patients whose disease had just progressed on a CDK4/6 inhibitor. So it was a single cohort that was presented, not a comparative trial. We know that from SOLAR-1, alpelisib added to fulvestrant improves progression-free survival in patients with a PIK3CA mutation. What do the data from BELIEVE tell us? Why is this important?
I think we were all very excited when we saw the data from SOLAR-1 really suggesting that adding alpelisib to fulvestrant was improving progression-free survival in those patients with PIK3CA mutations. But the problem, or the challenge in interpreting those data is that the vast majority of those patients in that trial had not received a prior CDK4/6 inhibitor. In fact, there are only like 20 patients in the study that had prior exposure to CDK4/6. And while initially the SOLAR-1 subgroup analysis of those patients suggested PFS benefit, I think we all really wanted to see, is this supported in larger numbers of patients? And so the BELIEVE data are quite important for that reason, since it is really now quite standard to use a CDK4/6 inhibitor upfront with endocrine therapy. And so in looking at the data that was presented at ASCO, they looked at patients who got fulvestrant and alpelisib who had PIK3CA mutations and found a median PFS that was a little over 7 months and a response rate that was almost 20%. And when comparing these, it's not a randomized trial, so we don't have a control arm with fulvestrant alone here, but we do have a lot of data for fulvestrant monotherapy from historical control, although very limited post-CDK. And clearly this is much better than we would expect in someone with a mutation, because we know median PFS in someone with a PIK3CA mutation to fulvestrant is quite short. So in my mind, these data did support the fact that there is activity for alpelisib post-CDK4/6 progression, which was reassuring. And I think there's also some interesting data that continues to get presented looking at toxicity from the combination. And I think we've learned with time how to manage toxicity better. With rash, we now have data to support use of prophylactic antihistamines. And certainly one has to be very good about monitoring for hyperglycemia and intervening early, particularly with metformin if needed.
Yeah, I thought the data was very interesting in that small subset of patients who were started up front with an antihistamine. The rate of grade 3 rash was around 9 or 10%, which is 50% lower than or half that of patients who used it only when rash developed. So I think we're gaining speed or we're gaining knowledge in how to treat these toxicities and mitigate them. It reminds me of the early data with everolimus. Aditya, what's the most challenging toxicity you're facing with your patients in the clinic when starting them on this drug?
Yeah, the 3 most common side effects that we've seen with alpelisib or PIK3 include hyperglycemia. That is an on-target side effect that occurs with this agent. And many a times we have to start metformin to control the blood sugars. The second one is rash, and it was good to see that with antihistamine prophylaxis, you can reduce the occurrence of rash. And the third is diarrhea. That is something that's seen across the PI3 kinase inhibitors, and sometimes drugs like Imodium have to be used. But I think the key is early recognition of these AEs and early intervention. Usually these AEs occur in the first couple of cycles. So we usually recommend that a patient has glucometer at home to monitor the blood sugars and also Imodium prescription.
Claudine, are you starting metformin up front in all your patients or some of your patients who may be higher risk for the development of hyperglycemia? How are you approaching this? from, sort of a preventive strategy, if you will?
I mean, I think as Aditya mentioned, it's, when we're sending patients home with these oral therapies that have all these toxicities, education is critically important. We're not starting everyone up front on metformin. We're just monitoring them closely, checking their glucose regularly. Obviously, their hemoglobin A1C is, titching up a little bit or a little high to start with, and we're doing it. But otherwise, we're just monitoring patients very closely in that particularly in that first month or so of treatment. And we found that in most patients, it's been fairly easy to manage that way.
So Sarah, just sort of last question on this topic here. Is it your standard of care now? Patient has progressed on a CDK4/6 inhibitor and let's say an aromatase inhibitor. What is your go-to second line approach based on the data we have now from SOLAR-1 as well as BOLERO-2? How are you approaching these decisions? And do all patients who have a PIK3CA mutation go on alpelisib, or are there some who you're going to still give everolimus to?
I think the data from SOLAR-1 and from BELIEVE do really support the need to do genomic sequencing in our patients to know which patients have a PI3 kinase mutation. And so generally after CDK4/6 progression, I do look to see if they have a mutation. And if they do, I usually am recommending combination therapy with alpelisib with fulvestrant. I think it is a challenge because of the toxicity profile. And so there are some patients for whom I have not administered alpelisib. Those are particularly patients who have severe diabetes. So I had a patient actually a few weeks ago who had sort of uncontrolled type 1 diabetes, and I felt like that was really a contraindication to using alpelisib. Another patient who had high BMI and not well controlled diabetes on metformin. So I think those are patients that I have felt uncomfortable about utilizing alpelisib in. But otherwise, for the most part, people have been doing better with the prophylactic antihistamine and early intervention. So I have thought about it. I think the question does come up of, who would you give everolimus-based combinations to? Obviously, the hazard ratio from BOLERO-2 and even from the precog study are very impressive, 0.4, 0.5. But that being said, it was in an era prior to CDK4/6 inhibition, so we don't have great data post CDK4/6. But generally, if someone doesn't have a PI3 kinase mutation, I am then usually using combination therapy with everolimus in that second line setting.
Okay, last question, Aditya, on this topic. Patient has received fulvestrant CDK4/6 inhibitor frontline. They have a PIK3CA mutation. What are you giving them second line?
It's a tough question because SOLAR-1 essentially excluded patients who had received prior fulvestrant. So one can argue that while SOLAR-1 didn't look at this question, we don't have data that it's negative. So one could switch the patient to fulvestrant plus alpelisib or even fulvestrant plus everolimus, as Sarah was mentioning, based on the precog study. On the other hand, BELIEVE trial did look at this question. It did allow patients who were on fulvestrant-based therapy to switch to AI plus alpelisib. So I would personally look for mutations based on plasma-based genotyping. And if someone has ESR1 mutation, then I would be inclined to continue fulvestrant plus alpelisib. But in the absence of ESR1 mutation, I would feel comfortable switching to AI plus alpelisib in someone who's received fulvestrant.
That's great. Very, very important, sort of clinically relevant question there that I've run into in practice myself.